Good morning, everyone. We're going to begin virtual cardiac rounds momentarily. Just want to remind everyone to please mute your microphone. This morning's cardiac rounds is going to be presented by Dr. Vijay. He will be presenting on antiplatelet therapy, AFib, and coronary disease. All yours, Dr. Vijay.
Thanks, Chris. Thanks, everyone, for coming this morning. Not surprisingly, I'm doing a talk that has something to do with PCI. But today I want to focus more on the medical side. And I'm just hearing some feedback. I don't know if someone has their microphone on. Chris, I don't know if you're able to mute people.
Yeah, I can mute them. I'm just looking at them. Right now, we're all good.
Okay, great. Thank you. So today we're going to talk about patients who need PCI with acute coronary syndrome who have atrial fibrillation. And obviously our biggest challenge in these patients is the balance between the antiplatelet therapy that is required for PCI and anticoagulation for AFib. And I hope to take you through a patient journey to understand the importance of trying to get it right as much as possible with available evidence. So this talk is sponsored by BMS Pfizer, and so I have relevant disclosures. And to mitigate any conflict of interest, this was completely independent in terms of the preparation of the slides and the content, etc. These are my relationships. So we're going to start with a case illustration that highlighted for me recently some challenges in the management of antiplatelet therapy in a patient in whom I had done a couple of complex PCIs. We're going to look at the evidence for and against triple therapy, and I'd like to bring up and define the role for aspirin as much as we can. And then we'll talk briefly about the use of long-term antiplatelet therapy in patients with coronary disease. And most importantly, I think we will review the CCS 2020 guidelines as it relates to AFib and PCI. I'm sure many of you have seen the notifications from the CCS that they are promoting these guidelines right now. And I think that these are going to be very helpful for us. And as always in these patients, we're going to talk about balancing thrombotic, ischemic, and bleeding risk. So this case is of a 60-year-old gentleman who has hypertension, has a large BMI, big guy, 6 feet. In 2016, he first presented with uncontrolled atrial fibrillation with heart failure and reduced ejection fraction. His initial EF was 35%. He had global hypokinesis and had been initiated after treatment for his heart failure with anticoagulation and amiodarone, converted to sinus rhythm. And then over a period of time, his left ventricular function normalized. He felt quite a bit better. Due to his high-risk presentation, he was offered pulmonary vein isolation, at the first occurrence of atrial fibrillation, but he declined, and eventually was lost to follow-up, and he had major issues with medications and stopped them due to cost. So he does okay, and then a few years later returns with palpitations and paroxysmal symptomatic atrial fibrillation and flutter. He's initiated on edoxaban 60 milligrams daily. He saw an electrophysiologist, and flecainide was recommended. And these are his other medications for hypertension that had been initiated at the time. So he has ongoing symptoms now, palpitations and irregularity, and he was actually scheduled for a pulmonary vein isolation. And at this point, his left ventricular ejection fraction, I believe, is improved, remains improved. So he undergoes cavotricuspid isthmus ablation for atrial flutter first in 2019. As I mentioned, he presented with both rhythms, and this was reported to be a difficult procedure. In April of the same year, he then returns for a pulmonary vein isolation cryoablation. And this was apparently uneventful, and the patient did well initially. But interestingly, for a period of several months after his ablation procedures, he started to have new onset intermittent resting chest pain, which was thought to be pericarditis. At some point, I think there was a trace pericardial effusion.
Hey, you just ate your egg. Hey.
I think.
Please mute your microphone on the other end. Sorry.
Chris, I don't know if you can just keep track of it and just mute people.
Yeah, I am, but it's very hard because people come in and out of the presentation.
Yeah, that's right. Yeah,
with their phones.
Yeah,
okay. All good.
All right. And he was given a trial of prednisone and colchicine. He had a presentation in the emergency department more than once, and his chest pain continued. And then finally, he was admitted to hospital, and his for one of the episodes of chest pain, his troponin was found to be modestly elevated, not even particularly convincing, but certainly elevated. And at that point, he was found to be in flutter with 4-to-1 block. So unfortunately, back in his rhythm disturbance, and now with a positive troponin, and really an undefined etiology for his chest pain. So a decision was made that he would go to coronary angiography to determine if there's some other cause for his chest discomfort. So I just want you to think about this question. We don't have the ability to do interactive polls here, but how long would you stop your oral anticoagulant for before this procedure? It's not the focus of this talk, but I think it's actually an important point. So think about what you might do before, how long you have to wait before an angiogram. So the answer is not very long, like 24 to 48 hours. We still see patients waiting longer periods of time than that. And I think what we know is that the longer you're off your anticoagulant for your atrial arrhythmia, the more probable you will have a stroke. The recommendations, because all of the drugs are quite fast offset, are really basically 24 to 36 hours. So the day before the procedure, you don't take the drug, and the day of the procedure, you don't take the drug. And that is sufficient in most cases, with the exception of dabigatran in renal dysfunction, which is closer to 48 hours, so 2 days prior to the procedure. So basically 1 day prior to the procedure, you can stop your medication and go forward with angiography. So the angiogram demonstrated a normal left main. He did have significant underlying coronary artery disease. So he had some diffuse modest LAD disease that was not significant by physiologic assessment. So we are left with occluded vessels in the circumflex and the right coronary artery. And the RC also had diffuse proximal disease. And at this point, as mentioned, his left ventricular ejection fraction was preserved. So these are his medications. Obviously, Edoxaban had been withheld for the procedure, and there's other drugs. And he had been started on aspirin and ticagrelor, 90 milligrams BID, at the time of ER presentation for this particular event, and had been also anticoagulated with fondaparinux. And he was accepted for PCI. So we went ahead and we fixed his circumflex artery. The question for you, again, not interactive, but what would you do with this man's antiplatelet therapy after this PCI? So he is on Edoxaban, 60 milligrams daily. He received aspirin just peri-procedure, and he's now on ticagrelor as well. So would you switch his ticagrelor to clopidogrel? And there's no absolute right or wrong here. We decided to switch him to clopidogrel because, first of all, the guidelines support that. Clopidogrel was the drug that was used most frequently in the trials that we'll talk about of AF and PCI. Of the two stronger thionopyridines, ticagrelor was more frequent than prasugrel, but it has been associated with higher bleeding in non-randomized comparisons. And one study of prasugrel demonstrated a substantially higher risk of bleeding, so that is basically not at all recommended in PCI with AF. What is your optimal duration of aspirin post-PCI? And this is what we're going to spend some time thinking about, because I think the messaging is confusing, and I think the clinical trial data is somewhat confusing in this regard. Would you just stop the aspirin before the patient goes home? Would you stop it at a week? 2 to 4 weeks, or would you carry on for months, which would be triple therapy? And I think most of us would not carry on for months, but the question is, even in the short term, what are we doing with aspirin? So in this case, edoxaban was withheld for 36 hours, as I mentioned. He underwent complex PCI of the circumflex, and then 24 hours afterwards, we transitioned him to clopidogrel and restarted his edoxaban. He was given aspirin for 2 weeks, and then it was discontinued. And then the plan was to bring him back for a complex PCI of the CTO, the chronic total occlusion of his RCA, in 3 months. And his edoxaban was again discontinued for a short period prior to that procedure. So I'll show you that procedure. So this is what the circumflex looks like a few months after. So it's been opened. And this is a challenging PCI. So, and I think that as we talk about bleeding and ischemic risk and balancing that in patients, we need to understand sort of what's happening in the arteries and what type of procedure we're doing. So the concept of very straightforward versus complex PCI is something I think that referring cardiologists certainly need to understand and communicate with their interventionalists to understand what has occurred. So this is a long occlusion in the distal right coronary artery. Hopefully you can see my mouse. I can move it to show you the area of occlusion. It's collateralized, and we're doing what we do routinely for CTO angioplasty, which is a bilateral injection so that we can see both ends of the blockage, and so we understand where our wires are going. And in these types of procedures, we use guide extension catheters and microcatheters to allow better, freer movement of the wire. We have a very stiff wire here in the distal vessel. And if you look carefully, it's clearly not in the right spot here. And so we need to redirect that. And there we are, able to redirect now into the true lumen of the distal vessel. And so we've actually imaged and ultrasounded the artery and the wire to know where we are, and we believe that we're in the true vessel distally. So we're going to start stenting this RCA now. So I initially placed a stent in the distal vessel, and the plan is to come all the way back proximally. But as soon as I placed the stent, I noticed that there was a filling defect in the proximal part of the stent here. So that is thrombus. So it could also theoretically be plaque prolapse through the stent struts if there is a lot of plaque. But the fact that the rest of the stent looks really perfect and that one area demonstrates a filling defect really suggests the presence of thrombus. So at this point, this is a very important event. It's, potentially could have complete closure of the vessel. If you're not anticoagulated properly, you could thrombose both vessels, the left and the right. So our first job here is to check the ACT, which is a measure of anticoagulation with heparin during the procedure. And we confirmed that it's over 300, which is our target for these types of procedures during CTO PCI. So it's not a heparin issue. The patient is responding and is anticoagulated. He was on Plavix. He did not stop that drug. So mechanically, what we're doing now is just trying to balloon it and get rid of the thrombus, and it was quite difficult. So I carried on, I think, stenting the rest of the artery, and we did some more ballooning, and eventually were able to get rid of the thrombus. We added integralin, which increased the antiplatelet effect substantially. And on the table, I asked him about his antiplatelets to make sure, obviously, have you been taking your clopidogrel? He said, absolutely. This is the final result. So we still have some sluggish flow here down in the PDA. So a good result, but not perfect. So I asked him about whether he'd been taking all the drugs, and it turns out that he was not restarted on aspirin prior to his PCI. So the only difference here is that he's on edoxaban, and he's coming to this procedure with clopidogrel only. Whereas if we compare to the prior procedure, he was on aspirin and ticagrelor when he went into that case, much like a regular ACS PCI. So I think we ran into trouble in that case because the patient was not on aspirin for that complex PCI. So this is a problem that we're going to run into periodically and very frequently. The intersection of atrial fibrillation and PCI is substantial. 15% of patients with atrial fibrillation have a history of MI, and 15% of them will require stenting at some point in their lives, both issues being very common, right? So, and these patients will be considered for various combinations of P2Y12 inhibitors like clopidogrel, et cetera, aspirin, and oral anticoagulation therapeutic options. The big balance that we try to strike here is between the needs of the PCI on the left and the needs of stroke prevention and AF on the right. So we are worried, obviously, about stent thrombosis, which is what I showed you an example of, an acute stent thrombosis. And that is very well prevented by our treatments for PCI, including aspirin, clopidogrel, prasugrel, and ticagrelor. And on the right side, unfortunately, on the right side, the prevention of stroke obviously is through direct oral anticoagulants and previously warfarin. And unfortunately, there's not a whole lot of interaction there in terms of benefit. And so we end up in this situation where triple therapy becomes the primary challenge, at least in the peri-PCI phase. And we don't have a definitive recommendation until recently with the CCS guidelines of what's the optimal duration of the different drugs. And we still don't actually. And there are literally millions of potential combinations. Warfarin is still in this analysis. We could probably remove that at this point, but regardless, there are millions of different combinations, and you will find in your patients that they come out on varying strategies for duration of the thienopyridine or the aspirin, and certainly the choice of oral anticoagulant. What we do know from a long time ago is, and the West study, which is a randomized trial of warfarin anticoagulation with clopidogrel and aspirin versus warfarin and clopidogrel alone, meaning this is the true trial of triple versus dual therapy, is that dual therapy is favored for less death, less bleeding, less ischemic endpoints compared with triple therapy. And we believe that a lot of this is driven by the significant risk of bleeding with triple therapy. So along came a number of seminal trials in the area, and I'm not going to belabor each and every study because we've all heard about them. I'm going to focus on some details that are relevant to the aspirin question for Augustus, but I do want to stop for a moment and compare these different trials and understand what they have contributed to the literature and to our management. So these are all trials which introduced direct oral anticoagulants, including rivaroxaban and Pioneer, dabigatran and Redual, Pixaban and Augustus, and edoxaban in the Entrust trial for the use of these drugs in the context of doing PCI. Now, if we look at the very first trial that came out, Pioneer, which certainly raised our interest in using rivaroxaban in PCI patients, it really was not a direct comparison of rivaroxaban and warfarin, but a comparison of dual therapy versus a triple therapy strategy. Whereas the dual therapy arm included rivaroxaban and a P2Y12 inhibitor, which was basically clopidogrel in almost all cases. And the triple therapy arm was warfarin with various durations of dual antiplatelet therapy. So there was one small arm that was more of a direct comparison, but for the purposes of AFib management, it was a heterogeneous intervention versus control. And this is a similar design to what was seen in Redual PCI with dabigatran and warfarin, and the Entrust PCI trial with edoxaban versus warfarin. So it's kind of a mixed comparison of both dual versus triple therapy, and also in the dual arm using the new drug versus triple therapy using the old drug of warfarin. So that's important in the background because it's not going to answer questions definitively around the aspirin use, for example. All the trials, the primary outcome that is important to note is bleeding. They were all underpowered for ischemic endpoints such as stent thrombosis. So they are focused on the consequences of triple therapy and not in terms of bleeding, and not the lost opportunity with only double therapy, meaning ischemic stent thrombosis endpoints. So If we're to take the three trials that I talked about as dual versus triple therapy, and the primary endpoint being bleeding, we know that they are all set up for success. Because we already know based on the West trial that dual therapy is better than triple therapy for bleeding. So you can answer this question before these trials are done. I think the devil lies in the details as to what else we can learn from those three particular trials. If we look specifically at the Gustus trial, however, this was the one trial that had a different organization. And this was truly a comparison of apixaban, the direct oral anticoagulant, versus vitamin K antagonist, and then a 2x2 factorial randomization to aspirin versus no aspirin after hospitalization. So post-hospitalization triple therapy versus dual therapy. So we're going to get most of our answers, I think, with respect to aspirin from the Augustus trial. So just another brief comment regarding comparison that's very important. I will bring up the concept of the enrollment window for the trial. So for the Pioneer study, patients were randomized quite early, within 72 hours of sheath removal. And then they were out of the hospital and randomized to their strategy. In the Redual, 120 hours. Augustus was different, 14 days, and Entrust somewhere in between, 4 hours to 5 days. And the duration of dual antiplatelet therapy, meaning effectively triple therapy in this context, was 6 months in the Augustus trial and variable durations in the other trials. So in all the trials, we need to understand that the use of aspirin was mandatory in the peri-PCI time period in all of these studies. And all patients were on aspirin 81 milligrams daily until randomization. So if we go back to the patient that I treated with 2 complex PCIs, the first PCI was done the way the trials would have done them, on the dual antiplatelet therapy, and then cessation of the aspirin at some point after discharge. But the second PCI was not done according to the way any of the trials would have suggested. The patient was not on aspirin. So I just bring this point up because to me it was illustrated by the trial, illustrated by the patient, and the management of that in the peri-PCI period of aspirin is pretty definitively involving aspirin at this point. So, but if we look at the duration of aspirin that patients had with these trials, the Pioneer study, patients really only had 1 to 2 days of aspirin and then discontinued at the time of discharge. Similarly short with the Redual and the Entrust trial, but quite a bit longer, up to 6 on a median time of 6 days of aspirin with the Augustus trial. And I've already told you that the other three trials, Pioneer, Redual, and Entrust, were not powered to tell us whether there's a cost to pay with respect to stent thrombosis. So here's the design again that we talked about with the Augustus trial. So every patient got thienopyridine, and then it was a true primary randomization to apixaban versus warfarin in this case, and then a sub-randomization to aspirin versus placebo. So this trial, we can actually answer the question of whether apixaban is superior to VKA, because it's an isolated comparison, and we can answer the question of whether aspirin is superior to placebo, at least with respect to bleeding outcomes. So I'm not going to dwell too much on the patient characteristics. We've all seen this trial presented and the details presented. The one thing I wanted to pull out of the characteristics is in this trial, there was a significant proportion of medically managed acute coronary syndrome. So there is guidance from this trial on what to do with patients who don't get PCI. It was a mixture of ACS, medically managed ACS with PCI and without, and as well as elective PCI. So the primary outcome is, for bleeding is pretty obvious. We don't need to dwell on this. We know that patients who had vitamin K antagonist, warfarin, and aspirin had the highest rate of bleeding. Those with apixaban and aspirin had a lower rate of bleeding. So we can say that apixaban is superior to warfarin in this case. And then if we compared the aspirin arms, we'll go to that in a bit more detail. So if we look at the subgroups again, just to bring up the medical therapy arm, because we don't talk about it too often, I thought I'd highlight that, is that patients who are undergoing medical therapy clearly favor apixaban versus warfarin for their atrial fibrillation. So I think we can take some confidence in that result. If we look at the use of aspirin, you can see that in effectively all important subgroups, there was a higher that placebo is favored and not aspirin, and this reflects the fact that there's a significantly higher bleeding risk with the addition of aspirin to either apixaban or warfarin. And this is similarly seen in the medical therapy arm, so we would not be giving our medical therapy patients aspirin. And if we look at the composite of death or hospitalization, there really is no significant, there is a significant reduction with apixaban versus warfarin, but really no difference with respect to aspirin from a statistical standpoint. However, if we start to look at the individual ischemic endpoints for which the trial was simply not powered, none of the trials were, we start to see that we, in effect, haven't completely excluded a benefit for aspirin. So I'm just going to bring your attention to overall mortality was not statistically significantly different, but trended towards favoring aspirin, meaning triple therapy. Cardiovascular death, not really very significant either. Stroke was equivalent. However, the risk of myocardial infarction was reduced, but again, not statistically significant. Stent thrombosis also moving in the correct direction with the use of aspirin, and urgent revascularization. So these are our ischemic endpoints, and this is the trade-off of not using triple therapies. The patients will potentially have more stent thrombosis, more myocardial infarction, more death, and more urgent revascularization. Although we know that they're going to have more bleeding with triple therapy. So these results are concerning, right? So I think based on the results of the Augustus trial, I don't think we can say that aspirin is not important post-PCI in the context of atrial fibrillation. But we do have to recognize that there's a trade-off with aspirin in terms of increasing bleeding versus a probable reduction of ischemic events. And the way that that plays out in each individual patient is for us to determine at this point based on balancing their underlying bleeding risk versus their ischemic risk. There have been a few meta-analyses since the publication of the Entrust trial, which have put together all of these trials to see if they can amplify or examine that signal with respect to ischemic events. I'm just going to talk about one of them in a bit more detail, which was published by our colleagues at Sunnybrook and ISIS. And they scoured the literature for trials and basically came up with the 4 same randomized trials that we have discussed. I'm not going to focus too much on the baseline characteristics. They're very similar to Augustus, a mixture of ACS and PCI patients. So the primary outcomes in all the trials were major bleeding. And then the secondary outcomes were ischemic endpoints such as MI, stroke, stent thrombosis, and the composite of death and ischemic events. So these are the forest plots of major bleeding on the top. So these are the 4 studies that we have already discussed. And we can see that, that to the left favors the experimental group, meaning that very similar to what we saw with the Augustus, the Pioneer, Redual trials, et cetera, that dual therapy is favored over triple therapy with respect to bleeding endpoints, the primary endpoints. And it's a similar demonstration down below. But if we look at death and ischemic endpoints, based on what I showed you from the Augustus trial, of the 3 trials that included significant details around these events, there is a trend towards less death and ischemic events in patients who received triple therapy for a period of time, meaning the addition of aspirin. And death, however, again, not statistically significant. And in both of these cases, they cross the line of Udemy, so they don't meet statistical significance. If we look at the individual endpoints, again, very similar to the Augustus findings, where stroke was no different, myocardial infarction trended towards being significant, and stent thrombosis trended upwards, but none of these actually meet statistical significance. And the lesson here is not that there may not be a signal. There's obviously a signal, but that we're underpowered to determine those outcomes. So there is a concerning signal of less efficacy with dual therapy with DOAC compared with triple therapy with warfarin with respect to death and ischemic events. And we would assume that this is driven by higher coronary ischemic events because both the DOACs and warfarin has similar benefit with respect to stroke prophylaxis, and the stroke data really does look like it's no different between the arms. But when we look at each individual endpoint, there's really no significant difference. So we have to then look back at the trials and understand exactly how the patients were treated in the trials and follow those findings. So just remember that all of the trials enrolled patients several days after the PCI. In the Augustus trial, it was up to 6 days of dual antiplatelet therapy at a minimum. And the PCI procedure was performed with dual antiplatelet therapy on board. And we do not know whether it's safe to go with a single antiplatelet drug. Therefore, during the first week following PCI, even if it's combined with a direct oral anticoagulant. And the reason we don't know it's safe, even though we have 3 other trials, is they are underpowered for ischemic endpoints. And we obviously have meta-analyses suggesting some potential risk. But the story of meta-analysis is obviously very interesting. This was another meta-analysis published in JAMA Cardiology in a similar time frame to the last one that I presented, which again tried to look at MACE, which is a major adverse cardiac events, as balanced with bleeding. So if you look at the odds ratio for bleeding on the x-axis and MACE on the y-axis, we can see the control is where the arrow is pointing to, VKA with dual antiplatelet therapy. And if you institute purely direct oral anticoagulation versus P2Y plus P2Y12 inhibitor, there's a significant reduction in major bleeding, i.e. moving down the x-axis, without a statistically significant difference with respect to MACE. So this meta-analysis included one of the ISTAR trials, this was actually quoted in the CCS guidelines. And I had a discussion with Dennis Coe about this, and his point was that the trials are heterogeneous. The inclusion criteria for trials is heterogeneous in the different meta-analyses. And I think the bottom line is that we're not going to get our answers just from putting all these trials together. The bottom line is we're just underpowered to answer the question. I'll touch briefly on what we do after 1 year. We have some guidance from this trial called the AFIRE trial, which is a trial of antithrombotic therapy in chronic coronary disease with atrial fibrillation. And patients in this case were randomized after 1 year of either PCI or myocardial infarction when they were considered stable to either rivaroxaban monotherapy versus dual therapy with aspirin and rivaroxaban. So this is a point where we're not going to continue the thienopyridine because we're beyond 1 year post-intervention. And there's a clear there's a clear finding of less major bleeding in patients treated with single therapy. So we do not have strong evidence at all for the use of aspirin long-term in these patients. And based on this trial, DOAC therapy with rivaroxaban has good evidence as a single agent for patients with both AF and CAD long-term after 1 year. So what are the guidelines telling us? So this is the most relevant slide from the CCS guidelines from 2020, and we'll just walk through it briefly. So there are 3 categories of patients that are identified. The first is patients receiving elective PCI without high-risk features for thrombotic events. Then there are higher risk patients undergoing PCI, like the patient that I would have told you about, either complex PCI or ACS. And then we have ACS without PCI. So if we go to the far right, ACS without PCI, I think the evidence, even from the Augustus trial, is fairly clear that dual therapy is sufficient in this case. The use of clopidogrel and an oral anticoagulant, a direct oral anticoagulant, and the clopidogrel use either for 1 month or 12 months post-ACS, depending on bleeding risk. We do not need to use aspirin in these cases, at least based on the available evidence. If we go to the far left, elective PCI, meaning non-inpatient, stable procedures with no high-risk features, the CCS guidelines are recommending dual therapy alone. They do comment in the subtext here that all patients should receive at least a loading dose of aspirin at the time of PCI. And these findings would mirror the PIONEER trial, for example, where they really just had 1 or 2 days of aspirin and then it was stopped at the time of discharge and there was no further aspirin. And then continuing with dual antiplatelet therapy selectively with dual therapy selectively with clopidogrel and the DOAC of your choice. And I find these recommendations probably the most concerning based on the aspirin data that I presented to you. I don't think we have definite evidence around the safety of this approach, and we have to approach it cautiously and individualized. And the guidelines, to their credit, do talk about individualization. So patients who are obviously at higher risk should have some degree of triple therapy around the time of the procedure. So aspirin and clopidogrel, and then a duration of aspirin. And based on the Augustus trial, which is the only trial which definitively shows some duration of aspirin, I would say a week of aspirin is probably a good strategy for these types of high-risk patients. Understanding that out to a month, we still have a trade-off in terms of stent thrombosis risk. So the higher risk the procedure, the less likely you're going to stop the aspirin at 1 week, and then dual therapy beyond that. And they've recommended all 4 direct oral anticoagulation regimens. I'm going to flip through that. So what are the patient factors that we need to consider when we're trying to determine whether they should have longer duration aspirin or not? So we have to balance, obviously, bleeding risk versus ischemic risk. This is a very important slide, so I'm going to spend a little bit of time on it. So bleeding risk, patients who are over 65, low body weight, patients who have high blood pressure, obviously prior bleeding, INR, and concomitant use of other drugs that increase bleeding. So we need to be watching out for this when we're doing PCI. And on the right side with ischemic risk, obviously there are patient factors that place them at higher risk of stent thrombosis, such as diabetes, smoking, chronic renal failure. We've talked about acute coronary syndrome and prior stent thrombosis is pretty obvious. But the angiographic features are important, and this is where you will need to either read the PCI report or certainly have a communication with your interventionalist. The underlying multivessel disease, multiple stent implantation, bifurcations, long stents, chronic occlusion intervention. We don't use bioabsorbable scaffolds anymore. So, and I think that really has to inform our recommendation around the duration of aspirin. So there is a North American consensus guideline. It's not a guideline, it's a consensus document in 2021, which I think is a bit more clear in terms of the use of dual antiplatelet therapy around the time of PCI. So they actually separate into the peri-PCI period versus 1 month. And this is for all patients undergoing PCI. And I think this is correct, that they should all be considered for triple therapy right around the time of PCI. So obviously you have to have a duration of stopping your oral anticoagulant just before and during the procedure, but there is a period of time where you will consider dual antiplatelet therapy up to 1 week post-PCI. And then it is not recommended to continue beyond 1 week post-PCI unless there are very high-risk features. And that's the primary difference with this. The European guidelines are very similar to what was presented with the North American guidelines, where they comment on the importance of the use of dual antiplatelet therapy. And you know, it's in our guidelines, the Canadian guidelines, but unfortunately it's not in the obvious table, it's just in the subtext. So just to reiterate the importance, the patient should be getting aspirin. And I'll just bring up the other issues that we always consider in doing PCI in patients with AFib. there are pre-procedural considerations, and we have this discussion about whether the PCI itself is an appropriate procedure, and whether there are alternatives to PCI, such as medical therapy or even coronary bypass surgery. And the issue of bleeding risk with atrial fibrillation enters into all that complex decision making. Obviously, we do the ischemic thrombotic risk stratification that I talked about. At the time of the procedure, patients who require oral anticoagulation at any point really should have radial vascular access, and this is supported by this consensus document. Obviously, femoral is associated with a significantly higher bleeding risk, even in patients without oral anticoagulation. And then stent selection is not so much of an issue anymore. We use exclusively newer generation drug-eluting stents, and we have pretty good evidence, particularly for the 4th generation DES, which we have available now. We have the Medtronic Onyx stent, that early cessation of thienopyridine at 1 month is safe in the vast majority of patients, particularly those at high bleeding risk. And we have that similar evidence for the Xience, the newer Xience stent and the Proma Synergy stent. And then post-procedural considerations, close monitoring with reassessment of risk. This is something probably that doesn't happen often enough, but it happens in a haphazard fashion when the patient shows up in the emergency department with bleeding. But patients' clinical features change, they become anemic, and we have to watch and be mindful of these things. And obviously reassess their other medical therapies and find out if they have any active bleeding while they're on their dual therapy or triple therapy. So here are my conclusions. Obviously, we need to estimate risk of the patients before they are undergoing their PCI in terms of their bleeding risk and ischemic risk. We need to minimize bleeding risk wherever possible. I think I've demonstrated to you that aspirin remains important, and based on the available clinical trial evidence, all patients undergoing PCI must have at least a loading dose of aspirin, and likely best to continue to the discharge or at least 1 week or 6 to 6 days post PCI. And we can use aspirin longer in select patients who are at high risk of ischemic events, either by virtue of their clinical presentation, but primarily procedural related factors. But there is a trade-off to be paid there with bleeding risk. And we do need more evidence on the duration of aspirin. We do not have randomized trial evidence beyond 6 days. The medical therapy ACS patients likely do not favor aspirin use. And thank you very much for your attention.
Thank you, Dr. Vijay, for that presentation. We'll go into the question period. If anyone has any questions, you can type them into the chat box, or you can use the raise your hand function. We'll leave it open for a couple of minutes.
I think Natalie has her hand up. Right?
I think so, yes. Dr. Ho?
Hey, Ram, can you hear me?
Yeah, I can hear you,
Yep.
Natalie. How are you?
Thank you so much. That was an excellent presentation. I just have a question about patients with poor LV function and LV clot. So I've got a patient who's got an EF of like 20%, an aneurysmal apex, and he was stented within just coming up to a month ago, and we found a large clot in his LV apex. So you've demonstrated really well that NOACs are better than warfarin in AFib. There's a paucity of data on LV clot. Do you think we can extend this to include LV clot, knowing that they're not really going to do trials to compare warfarin versus NOACs?
Yeah, that's a great question. I think you've hit the nose on the head that we don't have appropriate randomized trial data to answer that question. I think the clinical practice, however, is to use direct oral anticoagulation. There is some observational data. I believe Ottawa published something a couple of years ago, on the use of direct oral anticoagulation. And I think that clinical practice has moved in that direction. So I think that's a reasonable strategy. And again, I unfortunately have no randomized trial data to base that on. So I guess your choice in this patient is they're now on presumably aspirin and a thienopyridine, probably ticagrelor. Am I correct?
Right. Right, exactly.
and you have to choose a drug to add. Well, you have evidence that there is less bleeding risk with the direct oral anticoagulant as compared to warfarin. So I think that's pretty clear from the Augustus trial, right?
Right.
So I think that if you were to balance ischemic versus bleeding risk, you know, you're definitely going to have less bleeding risk with the DOAC. I guess the question is whether you'll have sufficient efficacy for that thrombus, and I think clinical practice would support you, even though the evidence does not. So that's what I would do.
Right. Great. Thank you.
Thank you. Anyone else have any questions? We'll keep it open for another 30 seconds. I don't think any more questions, Dr. Vijay. Thank you for presenting this morning. And just a reminder, this recorded talk will be up in a couple of weeks on our new website for Cardiac Rounds. Thank you very much. Everyone have a good day. And once again, thank you, Dr. Vijay, for presenting this morning.
Thanks, everyone, for coming. Have a great day.